Namrata, you're on.
Welcome everyone to this international webinar, which is being done by All India Ophthalmological Society along with the IIRSI. And this is a webinar which is on endothelial keratoplasty, and we have a galaxy of speakers with us today. And we have eminent speakers like Professor Catherine Colby from the Department of Ophthalmology and Visual Science, University of Chicago. She's also the president of the Cornea Society International. We welcome her to this webinar. Then we have Professor Benny Jain, who's the professor and chair of Department of Ophthalmology and Visual Sciences, University of Maryland School of Medicine. Welcome, Benny, again. We had him yesterday also, and thank you for being here today again. Dr. Elmer too, a very good friend of ours, who's very well known to us in India. And he's the director of Cornea and External Disease Service, Department of Ophthalmology and Visual Sciences, University of Illinois at Chicago. Then we have Professor Sophie Dang, who would be joining us soon, and she's from.
She's with us now.
She's with us, so she's from UCLA, Los Angeles. Dr. Ashwin Agarwal and Dr. Susan Jacob, who are from Agarwal Group of Hospitals at Chennai, and Dr. William Berry, who's from Eye Consultants of Atlanta, again from USA. We have eminent panelists with us, which includes Professor Mahipal Sachdev, who's the chairman and managing director of Center for Sight Group of Eye Hospitals and president of the All India Ophthalmological Society. Professor Terry Kim, who's from Duke University School of Medicine at Durham, USA, Professor Vishal Jhanji, and Dr. Rajesh Fogla, who's from Apollo Hospitals at Hyderabad. We also have our chairs, Dr. Amar Agarwal from the Agarwal Group of Eye Hospitals, and thank you, Amar, for coordinating this webinar, and Professor Rajesh Sinha, who's the treasurer of the All India Ophthalmological Society and professor at RP Center, along with myself. So I would first request the president of All India Ophthalmological Society, Dr. Mahipal Sachdev, to say a few words before we commence the webinar.
Mahipal, unmute.
Yeah. Thank you very much, Dr. Namrata Sharma, and it is indeed a pleasure to welcome all the foreign faculty, especially from US, to participate.
The audio is
not, you
yes.
Can't hear me?
Now it's okay, sir.
Okay, welcome everyone to this webinar where we have a lot of foreign faculty, especially from the US. And on this webinar that is going to talk about lamellar corneal grafts, and I welcome you all to this particular webinar. I think we will learn a lot from this regarding the keratoplasty, the new advancements that are there, and I think Amar on behalf of IIRSI and Dr. Namrata on behalf of AIOS have been very, very active in arranging this whole thing. So I think without much ado, we should start with this webinar, and there are lots of us who want to hear the experts in this particular field. Thank you.
Thank you so much for that welcome. And I now request our first speaker, Professor Catherine Colby, President of the Cornea Society International, to give her talk on DSO tips and tricks.
Thank you. It's a pleasure to be here. Okay, of course this worked when we tested it.
No, Catherine, get your presentation on, then press share screen.
Yeah.
Now
Can
sharing.
You see it now?
Wait. Yes, now I'm seeing it right now. Just wait.
You can click on the presenter view down.
Slideshow.
Down right at the bottom. There's a
And then it goes away.
Hit escape. Hit escape.
The end of the slide, so just go back.
No, hit escape first because you're at the end of your
Click on the first slide. First, click on the first slide and then go to slideshow.
Yeah, click on one and then click on slideshow.
Perfect.
It has to be magnified, I guess.
Please do the screen share.
Here we go. Okay, sorry about that.
Perfect.
Okay, greetings everyone from Chicago. It's a pleasure to participate in this webinar, really the wave of the future in the coronavirus era. I'm going to talk about Decimase stripping only and give you some tips for success. I don't have any financial interests in this presentation. I will discuss some off-label uses of ROCK inhibitors. So we've known for about 8 years that the corneal endothelium in Fuchs dystrophy is capable of self-regeneration. And these were shown both by isolated case reports and laboratory work. Since 2014, there's also been demonstration that simple descemetorrhexis, removal of the central endothelium in Fuchs dystrophy without replacement of the graft with a graft can lead to corneal clearance and a reasonably good cell count of about 1,000. Shown at the bottom of the screen is my initial DSO patient who was done over 6 years ago, and he maintains 20/20 vision, a cell count of about 1,000, and a nice clear cornea with 20/20 vision. So my first tip for success with DSO is to pick the right patients. This will only work in diseases like Fuchs dystrophy where there's some endothelial reserve. It will not work in pseudophakic bullous keratopathy where the endothelium has been depleted. You need to limit it to people with central guttae, no more than 5 millimeters in diameter. And the best results occur when patients have a preserved peripheral endothelial mosaic. We measure using our confocal superiorly, and if we see a cell count of about 1,000 or more, we know that they're likely to do well. You also need to consider that after you remove the endothelium, that the vision will be blurry for approximately 3 to 6 weeks before the patient's endothelium heals in and deturgesses the cornea. So for people for whom that would be a problem, you want to just consider doing a standard EK. And then finally, patients need to be willing to have an endothelial keratoplasty if the Decimase stripping is not successful. So I limit this to patients who have symptoms, not just patients who have guttae. You want to avoid monocular patients, patients where the Fuchs is too advanced, such as those with limbus to limbus guttae, patients who expect perfection. Occasionally we achieve perfection with this procedure, but it should not be an expectation. And then again, patients who have no symptoms. The second tip is to optimize your surgical technique. We do know that guttae appear to be toxic to the endothelial cells in laboratory models, and so you want to try to remove as many of the confluent guttae as you can, although you do not need to remove every last guttae. And you can leave some and the endothelium can still migrate around, but remove as much confluent areas as you can. It's important to be gentle with the cornea. If you dig into the stroma with, for example, a Rosensky hook, this will cause postoperative stromal scarring. And while this is not generally visually significant, it makes the surgeon unhappy to look at it when you see the patient after the surgery. Work from Mass Eye and Ear really showed that a smooth edge chair increases the success rate of the procedure, and it makes sense. So you want to try to have a smooth tear technique rather than leaving a lot of tags of Decimase. And then Greg Maloney has shown that to center the descemetorrhexis on the visual axis will lead to reduced optical aberrations. So here's a short surgical video. This is in real time. And I've marked a 4 millimeter central area, which encompass this patient's guttae. And I'm using here the Gorevoy forceps. They're a smooth tip, round edged forceps. You can see, like a capsulorhexis, sometimes you can't get it the first way you try to pull, and I go back and pull the other way. And this is, you just re-grab as necessary. It creates a nice smooth edge. and it's easy to control. But there are lots of ways to do this. For a number of years, I used the reverse Sinskey hook, taking care to not dig into the stroma. People use an IA. You can use other forceps. The end result is a nice smooth tear, and you can see here. So this is a 4 millimeter, no tags left, and this was in real time. This part of the video is about 50 seconds. So my final tip is to use a ROCK inhibitor after surgery. Again, this is not FDA approved. There are several available around the world approved for glaucoma. We have our first one in the US now, Reposidil, which is approved in Japan for glaucoma. We know that these agents have effects on the endothelium and that they promote both endothelial proliferation in vitro and corneal clearance in animal models. And again, Greg Maloney, who's been one of our innovative colleagues in this field, was the first to show that it could rescue 2 slow to clear DSO patients in 2016. Since then, there have been a number of investigator-initiated trials that are currently ongoing. One that's been published so far is by Marian Maxey from Chicago, and she showed in a randomized clinical trial of Reposidil versus no Reposidil after DSO that there was an increased cell count and a decreased time to clearance. Notarsidil is available in the US. There's not a lot been published on that yet. There are some studies in progress. There is one case report in the literature. Here's an example of one of my patients who had a 5 millimeter Descemet strip. She cleared in 3 weeks, and her 6-month cell count was 1,300. And she has now had both eyes done and is doing very well. So there's not a lot in the literature with ROCK inhibitors yet. You can see in those initial citations there that there's only a small handful that have been published, but many more have been presented. And I have kept track of over 200 cases published or presented at meetings. And shown on the slides is another one of my DSO patients who was treated with Reposidil, and you can see the confocal where the edge of the Descemet rexus is. So while anecdotal reports and small case series are nice, the way to show that something truly works is by generating level 1 evidence. And to that end, we are now currently conducting a multinational, multi-center phase 2 trial looking at Reposidil after Descemet stripping. This is sponsored by COA. Strict enrollment criteria: the patients will be enrolled after surgery if the DSO falls within the allotted limits. And our primary endpoint is endothelial cell count. At 3 months, we are exploring multiple endpoints. Obviously, the COVID-19 crisis has reduced our ability to get this trial up and running, but we do have several sites activated. So in conclusion, Descemet stripping only has been shown to be successful in up to 100% of patients in certain series. The clearance time is generally 3 to 6 weeks. It appears like Reposidil and possibly Notarsidil speeds up the process, turning non-responders into responders and increasing final cell counts. There are many remaining questions, as with any novel procedure, determining the optimal patient population, the best size and shape for the Descemet rexus, and the amount and duration of postoperative steroids. We look forward to the results of randomized clinical trials so we can actually generate level 1 evidence and get this approved for widespread use. I appreciate the opportunity to join here. I wish everyone a safe and healthy end to the coronavirus pandemic. Thank you.
Thank you so much, Dr. Catherine, for that talk and for insights into DSO. Now I would like to invite Dr. Benny Jeng to give his talk on DSEK tips and tricks.
Thank you very much, Namrata. I'm putting my slide up right now. Thank you for inviting me, and Amar, thank you for inviting me as well. And congratulations on a very wildly successful OPL from a couple of days ago. So I was asked to talk about some tips and tricks for DSEK, and even though this procedure has been around for 15, 20 years, I think we all still have little nuances that we can learn to help improve our patient outcomes. This in spite of the fact that you're going to hear about DMEK being more and more popular, I still think that DSEK has a role. And so we'll talk about 10 quick tips, starting from the very beginning pre-op through the end of surgery, that might help us with our practice. So I have no relevant financial interests. So tip number 1, pre-op, is to check the surface. So we've all seen this. We all know that this is corneal edema, and if we do EK, the edema will go away and we'll have an excellent outcome like this. However, it is very important to look very carefully. This could look like edema from far away, but if you look carefully, you can see that this is actually scarring. And if patients have waited long enough, then they get subepithelial fibrosis and scarring. This patient had an EK, but ended up with best spectacle corrected visual acuity of only 2150 because of this scarring and irregular astigmatism. With a contact lens, she could see 20/25, but that discussion has to happen before surgery. Number 2, if you're going to do EK, I would highly recommend doing either ultra thin or nano thin, so less than 100 microns in thickness of the graft. 15 years ago when I did DSEK, you can see here this is 150 microns. We even used tissue up to 200 microns. And we know now that compared to the thicker grafts, in general, we accept the fact that thinner grafts tend to have better corrected visual acuity, faster visual acuity, and definitely lower graft rejection rates. And so there's definitely a benefit to doing thinner tissue if you're going to choose to do DSEK. Number 3, don't strip the area by the wound unnecessarily. What do I mean by that? There's a tendency that if you're stripping and you pull the tissue, you might just want to pull the tissue right by the wound and pull the whole graft in. Be very careful to actually strip that area right in front of the wound so that you don't pull all the tissue away. What do I mean by that? So magnified, this is the area where you don't want to unnecessarily strip that tissue. In front of the posterior lip of the wound, and where you should be stripping. You want to preserve as much of the tissue as possible. For DMEK, it's a little bit different. You oversize the stripping, but for DSEK, don't strip unnecessarily. Number 4, rough up the periphery. So I don't advocate being too aggressive, but I think a little bit of roughing up, even with a Sinskey hook just at the very periphery here, actually does help with the adhesion. I really do think it works. On the flip side, what we used to do, which was venting incisions regularly, I don't advocate doing these regularly. Why do I not? I think that the benefit of it has not been shown to be that great. Studies have shown that if you wait long enough or have enough pressurization, then any interface fluid will go away. But there are probably some roles where if you really can't get the interface fluid to go away, that maybe you could do this. The downside of doing this regularly is that epithelial ingrowth is definitely a problem. And I have had several cases in the past of irregular astigmatism from these incisions. So I'd recommend not doing these on a regular basis. Number 6, trim the tube. Okay, we know that if there's a tube there, most likely it is the cause of why we're doing EK surgery. But if we're not going to actually put that tube into the pars plana in behind the iris, then at least get it out of the way, because that tube, the longer it is, the more trauma it's going to cause to the cornea, no matter how well placed your glaucoma colleague thinks that it is. Number 7, know how to do one technique really, really well. So the technique that I usually go to for this 90% of the time is with the Endosuture. I think that at this point, all different studies will say that the results are probably equivocal. So pick a technique, do it well, learn all the nuances of how to get it done successfully, and in general, your outcomes will be very, very good. The corollary to that is know how to do other techniques as well, okay? Just knowing one technique is not usually good enough. Dr. Tu is going to go over his suture pull-through technique, which I learned from him, but this is great for aphakes. Dr. Barry Lee does this very elegant, very quick sheath glide technique. There are other pull-through techniques, either with the endo glide or the Bucine glide. And then, of course, if they don't send what you need and you have to do folding, you really ought to know how to fold and get the graft in. You could even do it. You try to forceps if you have to. And so it's important not only to know how to do one technique well, but you should also need to know how to do other techniques to get you out of jams. Number 9, during the time, whether it's 5 minutes or 10 minutes or 12 minutes that you're going to wait for the eye to pressurize before you do the air fluid exchange, if the graft moves at all, give strong consideration to suturing it. Why? Because if it's going to move under those controlled circumstances, it will likely move postoperatively when the patient's not in your sight. And so you can have something like this where the graft is detached and settled inferiorly, or it might be attached, but it might have moved and slid either inferiorly or superiorly. So if it moves while you're watching it, you ought to suture it. And number 10, if you're going to suture it and use a retention suture, place it inferiorly. Why do I say that? Because the default is that the air bubble is going to go superiorly because the patient's always going to be slightly inclined. So why not have some securing inferiorly with the suture if you're going to do it, and then the air bubble will help retain it up at the top. And this generally ends up with a very, very good outcome. You can still rebubble at the slit lamp if you need to, but an inferior suture is what I would recommend. So in conclusion, you know, there are a lot of nuances to doing DSEK, and people have gotten very, very good at it. But if you can keep in a couple of pearls to help, your patients will do very, very well. Thank you for your attention and good luck.
Thank you very much, Benny. It's such a pleasure to have you with us here. I thought we'll just ask Catherine one question is, do you suggest that people be ready with the patients? Suppose it fails so that they can go in for an endothelial keratoplasty rather than just sticking to a DSO?
Yeah, I always counsel patients that they may need to have an endothelial keratoplasty. Generally, we make the decision anywhere from 6 to 12 weeks. Sometimes people are slow to heal, but if they stop healing or if they get frustrated or you've reached the 3-month point and they're not healed, you should just proceed to your EK of choice.
And what about you, Terry? Are you using DSEK? What thickness are you using, Terry?
Primarily, really DMEK and DSEK for complex cases. And I've found that to be a pretty good approach. I've only tried DSO in one case that was kind of like an endothelial scar from an inadvertent touching of the cornea that was referred in. And you made it look very elegant, Kathy, when you were stripping Decimates, but sometimes it's a little piecemeal, doesn't come out nicely, maybe in that particular scenario. And I was curious for you, does the edge congruity make a difference in terms of visual acuity quality? Because in my patient, the edges are a little irregular, and I find that this patient's still having some glare. Are there some, you know, tips for that in terms of helping patients that may still have, you know, visual aberrations?
So I think you want to make sure it's centered on the visual axis as much as possible. You want to avoid digging into the stroma. For years, I did this with a reverse Sinski hook, and patients were happy. But I would make very small kind of maneuvers in the eye. I wouldn't like do a big scrape, and really make it more like, you know, those of us who are old enough will remember when we did anterior capsulotomies for cataract surgery, and it's the same kind of maneuver, only upside down, but really try to make as smooth of an edge as possible and not leave tags and center it. But I agree, they don't all come off that nicely. That's why I show that one.
Dr. Rajesh Fogla, your take on DSO? Rajesh Fogla?
Well, we don't see patients in the early stage as what they see in the US. By the time patients come to us with decreased vision, the extent of Gate are much wider. And I think Samar Basak has had some experience with DSO. And in fact, one of the last presentations that he made, he found recurrence of Gate at 2-year follow-up within the area where he had done the Decimate stripping only. So for the time being.
Yeah, go ahead, Rajesh.
Yeah, so I think it is about selection of cases rather than. And you're right, here we don't see that very early cases, or probably don't pick them up. And our severe cases are so severe that, you know, you land up just doing endothelial keratoplasty for those cases.
Liz, what about you? Are you doing DSEK? What thickness are you using? Anything you can tell us?
Sure, I certainly agree. Benny, beautiful presentation. With regards to the thickness of the DSEK, for myself, I prefer 60 microns, which is kind of on the higher edge of a nano-thin, on the lower edge of the ultra-thin. When you get a little bit thinner than that, it does tend to scroll a little more like a DMEK, and it kind of poses a little bit of a challenge there. I do prefer a pull-through technique using my Buzin, but I could not agree more that it's so important that we do know how to utilize different techniques. And DSEK is my preferential technique to go to instead of DMEK if I'm going to do a triple with a cataract surgery, because it's a lot easier to maintain a nice deep chamber than to have a super shallow chamber doing cataract surgery. And truly visual outcomes, while it may take 2 to 3 weeks longer, they really do come out really well. And then ultimately with my wounds, I always make them a little bit shorter, as Benny mentioned, because you want to make sure that there's no crossover between the inner lip of any of your wounds and where your DSEK will overlie, because that certainly can leave a certain level of vulnerability for potential non-attachment.
Oh, there's one more question about Riparsodil, because ROCK inhibitor, like you suggested that we could use it post-operatively, but the counterpart that we have in India causes congestion. So I don't know if you all have experienced the same in US.
You mean it causes conjunctival hyperemia?
Yes,
Is that? Yeah, it does. I would say maybe 10% of patients have it. You're not using it chronically like you are for glaucoma, so patients can usually manage the redness for the time that they're on it.
Kathy, beyond the redness, is the comfort level of that drop good? Because I know there is some discomfort, that can be associated with ROCK inhibitors.
I don't know if my patients are just so eager to get better that they're not telling me, but no one complains about it being uncomfortable to use.
Kathy, how long do you treat them with your?
So I treat, well, and again, let's say this the right way. I don't treat them because it's not FDA approved. They get the drug and I monitor them while they're using it, and they use it until the cornea is clear 4 times a day, and then it's a pretty rapid taper over a week or 2, depending on how much of the drop they have left.
Because we're about to publish an AJO, our series of patients who have this reticular epithelial cell edema. Some of it may be associated with the Nutarsidol that we're using. And so we're finding that we're using it only for a certain time period, like 2 weeks, and then we stop it. And so we're just still trying to learn the best time to use it, when to use it, how long to use it, at least with Nutarsidol, which is FDA approved here.
Yeah, the honeycomb edema is known. Not every patient gets it, and I think it's slightly less common when you're using it 4 times a day. I haven't used Nutarsidol for after DSO, but yeah, it's well known, but it resolves.
Susan, you had a question?
Yeah, Kathy, I wanted to know, is there an upper or lower specular count that you look at preoperatively, and also do you look at the peripheral specular count as well, or is it just the central one that you look at?
Well, so most of these people, you can't detect any cells by specular. So I use confocal, and I look at generally the superior cornea, because I figure that's going to be the best cell count because it's been protected by the eyelid and doesn't have as much UV exposure. But yeah, I mean, I think it is important to do some sort of analysis of the peripheral endothelium. You want to make sure that the cells look relatively healthy and that there's enough of them to repopulate. But you can, you actually can do that with a clinical exam on high mag with your slit lamp.
Thank you very much, Catherine. Namrata?
Yes, so I think we move on to the next talk with this, and the next talk is going to be given by Dr. Barry Lee, DSEK in difficult situations.
Okay, everybody see that?
Perfect.
Okay, so I don't have any financial disclosures for this talk. So I think the big question is DSEK still relevant? We've already talked about that already this morning. We think everyone's doing DMEK and PDEK, right? So if you look at the statistics, it's really not so true. From 2010, we've seen a big shift in our EBA statistics. This is all the eye banks in the US that are reported. And you can see still 60% of the endothelial keratoplasties, at least in the US data, is still DSEK. So it's still the more common procedure performed, as you can see here on the breakdown. So 60% of the EKs in 2019 were actually DSEK. And I think it's, Terry mentioned this earlier, it's the complex situations where I think DMEK or PDEK might be a little bit challenging. And that's kind of where I'll go to doing a DSEK. I do probably 75% of the cases now with DMEK and 20% are with DSEK, but it's these complex situations where I think the DSEK tends to work better. So I've got glaucoma, severe corneal edema, and a cloudy cornea, aphakia. We have a talk on aphakia coming up, so we won't do too much on that. Anterior chamber IOLs or dislocated IOLs. Amar's shown a lot of videos, and Ash as well, where they've done PDEKs along with dislocated IOLs, and that can be a pretty challenging situation where I think a DSEK could be helpful. And then I'm going to show a video of a shallow anterior chamber and a very short eye, almost a nanophthalmic eye with a lot of posterior pressure, and just show a video of doing a DSEK on that case. So obviously the tube shunts, you saw a video earlier where that's been trimmed, can be particularly challenging. Here's one of my patients. It's thought that DSEKs with tube shunts don't last long. This is a patient I just saw last month. I did this in 2006, and this picture was from last month. The DSEK is still clear. You can see a tube shunt at 1 o'clock and another tube shunt at about 5 o'clock. So they can last for a long time in some rare situations. Here's a patient with an anterior chamber IOL and a Zen stent, and you can see here how the DSEK is very nicely clear over the shunt and the ACIOL. And obviously the problem with a trabeculectomy or a bleb is that the air, as you can see, your air has gone into the bleb as I'm trying to inject it intraoperatively, so that can be a challenge as that air really sucks out of the anterior chamber. Cloudy corneas are a particular challenge for DMEK procedures. This is a disciform edematous patient. It's now got a lot of scarring. So as Benny mentioned, if you're going to do a DSEK on this patient, you really need to think about can you reduce the scarring with steroids, and will you need a gas perm contact lens afterwards? But this, you can see how a DMEK on this case would be really challenging. This is an intraoperative patient where I've actually removed the epithelium because it was so cloudy, and you can still see the view is pretty poor. This is a dark iris. It's tough to see the staining on DMEK tissue sometimes in a dark iris, especially when the cornea is very edematous. I think the thickness here was almost 900 microns. So this would be a particularly challenging one for a DMEK procedure. Here's a decentered and failed DSEK graft, and you can see just this was over 1,000 microns on pachymetry. That would be really challenging to strip this and be able to see to do a DMEK. And then another patient here with severe pseudophakic corneal edema and glaucoma, again, where the pachymetry was over 1,000 microns. So those are cases where the staining, the vital dye staining with a DMEK procedure would be pretty challenging. Hopefully the Americans are watching Ash and Amar and Susan so we can learn more about PDEK. As you saw, the PDEK numbers on my statistics were pretty low. Here's an aphakic patient presented after an airbag injury. So it caused corneal edema and dislocated cataract in the back of the eye. Here's another patient referred to me for aphakia that had severe corneal edema. The retinal surgeon here had done a pars plana vitrectomy and lensectomy and then sent to me. And this was before the custom flex iris implant. So I used a blue Optec implant and then did a DSEK on top of that at the same time. So gave a nice cosmetic result and resolved the corneal edema from the injury. And then we have anterior chamber IOLs. This is certainly controversial. I think if you see, as this anterior chamber lens is really well placed, it's nicely, the haptics are nicely in the anterior chamber. The anterior chamber depth in this patient's about 4 millimeters, so it's a good AC depth. So this is a cornea where if it decompensated, I wouldn't be too concerned about exchanging the IOL. I might just go ahead and do a DSEK. But certainly if the anterior chamber is very shallow or the anterior chamber IOL is poorly placed, you'd probably want to think about doing an IOL exchange, doing a glued IOL or Yamane technique to fixate a IOL to the sclera and then do your DSEK on top of that. Again, those are cases that might be tough for a DMEK. So just kind of review this case. This is a patient with a 69-year-old female, very hyperopic, +9. She'd already had a corneal transplant in the left eye and had a high amount of astigmatism. Didn't really like to wear a contact lens. You can see she saw fairly well when she wore the contact, but the right eye had deteriorated significantly to 20/80 on Snellen acuity. She had fairly advanced fuchs dystrophy, and then both eyes had cataracts. But the axial length was 19 millimeters, and the anterior chamber depth was 1.9 millimeters. So really kind of a challenging case to do, and I was planning on doing a DSEK phaco. Just to start the video here, I like to make the incision initially to 2.8 millimeter corneal incision. You can see the viscoelastic immediately burped out of the eye as soon as I injected. That was Helon. And you're going to see here, as I go in with a Yatrata, the iris is already starting to crimp up in between my Yatrata forceps. And so I'm having to be really careful here, because if I go too fast, I'm going to strip the iris. See how the iris is coming through the forceps again, and now it's starting to prolapse. So just really having a hard time managing the anterior chamber. So I'm going to come out here. I'm going to put in a Helon GV, which is a little bit thicker, cohesive viscoelastic, to push the iris back in. Finish my capsulorhexis. And again, just trying to keep the chamber formed. You can see the iris is starting to prolapse again. So this is a little trick on these cases I like to do, and this is helpful for phacos too, is make a little stab incision behind the incision. And I'm just going to take an iris hook. You have to be really careful here, right? And I first initially almost got the anterior capsule edge, and don't want to do that because it'll rip. I'm going to catch it again here with the hook. Let's see if I can speed that up for time's sake. And here what I did is I actually put a little bit more viscoelastic in between the iris and the anterior capsule, and that's going to give me a little bit more space to work with. And now the hook goes right in, tie that in. And so now you don't have to worry about the iris prolapse for this entire case. So I'm going to go ahead and just skip the phaco part of this. I ended up putting in a hydrophobic acrylic IOL. If I can speed that up for time's sake. Stripping the endothelium. Now, when I do a DSEK phaco, I don't mark the cornea because the iris is a great marker for you. So it's sort of a wasted step for me. So I'm just going to follow the pupil edge here, and it makes for an excellent mark without having to use any pens or marking agents. And again, here using a Sinskey hook to strip it out and then pulling out the tissue. You can still see the iris is behaving great with that iris hook, even though the AC depth is just really shallow here. We're going to take that out. Now I'm going to remove the hook. This is the step where you want to get rid of it, and then you'll do your viscoelastic. And at this point, I'm going to enlarge the incision. I think I edited this out, but I'm going to enlarge the incision for 2.8 to about 4.5 millimeters. And then I'm going to put a sheets glide. I think Benny showed this technique earlier. I like to do this on all my DSEK cases. I don't really find that I need any other techniques. So we're going to fill up the anterior chamber. I'm going to really coat the sheets glide vigorously with viscoelastic. And you'll see I use a lot of viscoelastic here so that glide is completely covered. And then I'm going to take the DSEK tissue. The eye bank has already pre-cut it. This is probably about, like Liz says, like about 60 to 80 microns. We're going to grab the lip of the wound and then take a 30 gauge needle. And you'll see on this really shallow anterior chamber eye, this really works pretty easily. It does try to come out here a little bit as I'm coming back, so I'm going to push the tissue here a little slower. And then I'm going to fill the anterior chamber up with a little bit of BSS, try to give it a little bit of shape. And then I usually will put in 2 interrupted sutures. These are 10-0 nylon sutures, and then do your DSEK air bubble. So you can see how that little trick with the iris hook really helped make this case manageable. That would have been impossible to do with forceps delivery. It would have been challenging to do with having to come across the anterior chamber with a Boost and glide. And so the sheets glide technique really helped me on that situation. So just in summary, obviously I showed the statistics. DSEK is still relevant, at least in the eye bank statistics here in the US. We're about 60% now doing more DSEK than DMEK or PDEK. And I think challenging situations are really the cases where DSEK can be helpful, where DMEK might be a little bit more challenging, aphakia, a large iridectomy, cloudy corneas, and certainly IOL problems. But I think Benny mentioned it earlier, just knowing multiple techniques and then trying to figure out what the best technique is for you is really the way to be more successful and to deal with some of these challenging cases. And certainly having DMEK and PDEK in your toolbox is also going to be helpful for some of these other cases. So thanks for your time. I appreciate Amar, Susan. I appreciate the opportunity to speak today. It's a great
Thank you very much, Barry.
Thanks so much, Barry.
Namrata.
Thank you, Dr. Barry Lee, for that very nice presentation on challenging cases. And now the next speaker is Dr. Elmer True.
Oh no, just kidding.
Who's going to be speaking on suture pull-through DSEK. Dr. Elmer True is very well known to us because he's taken numerous courses on DSEK at our center, RP Center, All India Institute of Medical Sciences, as well as all over India. So we are thankful to him for having taught us DSEK. Yes, Elmer.
Elmer, you need to unmute.
Yeah,
Unmute.
okay,
Elmer,
sorry,
unmute.
I'm off now. Anyway, I'm not sure that I taught anyone anything there, but the surgeons are excellent in India, and we've learned a lot also from our interactions. So I very much appreciate the opportunity to present as part of this conference. And thank you, Amar. Thank you, Dr. Namrata, for all the support that you've shown us over the years. Sort of in the vein of what Barry and Benny have talked about, is that DSEK still has some relevance, I think, in our world. In some of these more difficult eyes, I think that it's still a very good technique, and it also has something to do with the patient compliance. I'm going to present something that I started doing many years ago, which is a suture pull-through technique for DSEK. The first parts of the procedure are standard with the descemetorrhexis. This is a very quick video just showing you with the synopsis. This is one of the original procedures that we had done with a straight needle. And you can see the imbrication of the tissue. And then the wound is created here. There is an anterior chamber maintainer that is basically on surgeon control. So you can control the anterior chamber as you like during the procedure. You may not use it at all, or you may need it in certain aspects or certain points during the procedure. So after removing decimes, the tissue has been pre-prepared by you in imbricating it. It's a double arm suture. This is a horizontal approach where you're basically taking one needle across and then you follow it with the second. Excuse me. And then you basically just grab the suture, and through the incision, you bring the suture into the anterior chamber. You can see the graft centers very nicely. Once you close this and the anterior chamber starts to deepen, often the tissue itself will open spontaneously, but otherwise manipulation is fairly easy. You can use a needle if you want to move the tissue over. This is a situation where we had removed the suture and centered the tissue with the needle here with a final air fill. Just to focus in a little bit on some of the parts of the procedure that are a little bit different than a standard DSEK. And here is the preparation of the donor tissue. You cut the posterior lenticule as you normally do to your desired size. You want to place just a very small amount of viscoelastic in the interface or on the endothelial side. The needles that we use now are the CTC6 needle, which is an ethicon needle. It's bent, and you're going straight through from both sides of stroma, and then the needle is actually buried into the cap so that the needle head comes out and is easy to grasp on the other side. Here you can see the entire preparation of the donor tissue does not involve touching or squeezing the tissue in any way, and this is just placed aside, and then you can go ahead and start preparing the recipient. And the graphical appearance of the tissue at the end is shown on the bottom right. Insertion of an anterior chamber maintainer is important. This was a combined procedure, so we actually did it after the cataract surgery, which makes it a little more challenging because it's the chamber is fairly soft. But the one thing you want to do is to make sure the anterior chamber maintainer is directed away from where your graft is and isn't involved in where the graft will eventually sit. Again, this is usually on foot pedal control and is only used when the chamber seems to be unstable when you're passing those sutures that I just showed you. Just a brief word about the corneal incision size. Usually you can use a keratoma of basically any size, but the wound we normally would be about 0.5 millimeter larger than half of the diameter of the folded tissue. So if it's an 8 millimeter graft folded 50-50, I usually make the wound size about 4 to 4.5. It can go through a smaller one, but the tissue does get squeezed, I think, as it goes through, and it may get distorted, and you may have some endothelial damage. So it's always better to go a little bit larger than smaller than you need to. And one distinction from what was talked about earlier, I actually make my corneal wound longer and have the internal portion of the wound within the area where the DSEK will sit. And the reason for that is that when the DSEK is opened, it will actually tamponade the internal opening of the wound. And see, these patients actually have very stable wounds, are easy to suture. Once the graft is open, the air stays and will not come through the main wound, even if there's some slight gap there. So I have a tendency to make the corneal entry wound longer rather than shorter to actually be involved in the area where the DSEK will be. The key here to passing the suture is really two. One is to make sure that you have the correct suture on the correct side, because there's a right suture and a left suture. So when you open up the tissue, you want to make sure that they're not crossed. The second part is what you're going to visualize here in the video, is that once you're in the wound, you want to sweep that needle right and left to make sure you haven't caught any fibers of stroma as you've gone across. The most disappointing thing is that when you go in, not realizing it, and then realize that your graft won't go in because you have some suture or some stroma actually in the suture itself. So that's a very important step, is to go into the wound and make sure you sweep across to make sure there aren't any fibers of stroma that your needle have caught as it's gone across the anterior chamber. These needles, as you bring them across, it's better to be further than closer. You'd rather not have the needles come out early, but you can very precisely place where this graft is going to be. And this is especially helpful in patients who have had graft failure, for example, from a PKP. You can very precisely put the transplant exactly where you want it. You can see the sweeping motion. You bring across the needle. This is from a superior approach, and you come right through the cornea on the other side. Once that's through, you will see that you can just bring the suture across, and once that's taken through, you'll have a double arm suture attached to your graft, and then you can just pull on the sutures. People will often take some time trying to even up the length of the sutures. It's really not necessary. It's very self-regulating, so that if you pull both of the sutures on the other end, any excess suture on the right or left-hand side will equalize without any difficulty. So you can see here, you just grasp the suture there, and you can bring the suture or the tissue onto the field. You can see graphically it's being shown down below what happens, but you basically have the tissue right into the wound edge, and then once it's tucked in, you can just bring it into the anterior chamber, and you can see very nicely that the graft is centered fairly well within the marks that you had done your capsulorhexis. One of the things is that when you bring this tissue across, occasionally there may be a little bit of tissue still in the wound. All you need to do is tap on that wound, and that should bring the posterior part of that in. Most of these sutures will require just a single suture. Being around 4 millimeters, you really don't need much more than that. I have actually done these sutureless occasionally, again, because the internal part of the wound is tamponaded by the open DSEK tissue, but I really haven't found that to be that helpful in terms of astigmatism or anything else. So once you do this, you'll find that you've probably noticed from the video that the graft is already spontaneously opened. So once the chamber is deep, you have the tissue being brought up to the posterior surface of the stroma by the original proline suture, and so the graft has room to open underneath. So it actually works very well and requires very minimal manipulation. After you're finished with suturing the wound, you'll tie off the proline. That can be left in place, and with a superior approach, as Benny was recommending earlier, if you feel that there's a concern about graft dislocation, you'll have a pre-placed stay suture there for your graft, which causes very minimal striae, as opposed to having to put it in later. Normally, I'll tie this proline very loosely so it doesn't cause any striae, and the knot is left out, and usually we can remove that the following day as long as the graft is well centered and attached. I've left it in for several weeks in certain patients with glaucoma procedures and that where we're unable to keep the chamber deep and pressurized. So it is well tolerated even for that length of time. You can put a bandage contact lens over it if you want to help with discomfort. So in summary, this technique allows a very atraumatic graft manipulation. Over on the right, you'll see the video showing the DSEK done in a patient with an abnormal pupil and aphakia. One of the advantages is that stay suture will prevent the graft from entering the posterior chamber at any time. And so that's certainly helpful in aphakic patients, but this also can be helpful in ACIOLs, patients, as I mentioned, who are hypotenuse from glaucoma surgery or have other unusual anterior segment anatomy. For the beginning DSEK surgeon, this is excellent because there's no chance of graft rejection, or I'm sorry, graft ejection with the anterior chamber maintainer in place. The suture will prevent that graft from ending up on your lap. Really, this involves the smallest incision possible, really, for any folded graft that you can put into the anterior chamber, and is really largely a single-handed technique other than holding the graft. The other nice thing about this is it's a very inexpensive disposable delivery system. It's probably something you have in the operating room right now if you do any type of IOL manipulations. We use these Ethicon needles, but there are analogous sutures that are available everywhere else. Really, any long needles, whether it be straight or curved, can be used for this particular purpose. On the bottom is an aphakic, completely flat anterior chamber DSEK that we had done probably over 12 years ago, which is still clear now, in a one-eyed individual who has rubella. So thank you again for your invitation to speak today. I hope this will be somewhat helpful, and I wish you all the best of luck.
Thank you, Dr. Almer, for that wonderful presentation. And I think this technique is very useful for, in fact, like you said, all kinds of cases and very predictable. And now it is my pleasure to invite the next speaker, Dr. Sophie Dang. She's going to be speaking about DMEK tips and tricks. So we have to
myself. Yes. Here. Can you see my screen?
Yes, Sophie, you're on.
Great. First of all, thank you very much for inviting me to share my experience on DMEK, especially tricks and tips in difficult cases. And the go-to technique I use is called touch but no touch technique when I do the DMEK. And I will use the ICL injector. I fold the graft in double scroll facing a position and inject it into the anterior chamber. And be careful when you withdraw the injector, make sure the graft doesn't eject it out, as what Alma mentioned. The go-to technique that I use is this single cannula technique. This double scroll facing a position, so the cannula inserted into the interface using a tucking motion, and this is real time. You can see the slowly tucking it, and the graft will unfold quite easily. So this is the way that I unfold my tissue. So the tips on DMEK, I think, is all about controlling every step of the procedure. Always think ahead and prepare for the next step. For example, I show you that fold the graft in double scroll facing a position before you load it into the injector. So once the graft inside the eye, the graft is already half unfold. So half the work has been done. The second tip, I think is the most important tip for a successful DMEK is controlling the anterior chamber depth, and it's critical. I'm going to show you two ways to control or create the depth or shallow the anterior chamber depth. The other one critical success for a long-term survival of the graft is to control the movement of the graft in the anterior chamber. I do not like flipping the graft. I do not like any upside down graft. So I show you the technique that very controlling, in a very controlling fashion. The graft is inside the AC, but there is little movement when the graft is being unfolded. Again, what Benny said earlier is I learned multiple techniques, and sometimes in some conditions that different techniques will be very useful, like tapping technique that is very helpful in certain situations. So the trick number one is how to keep the anterior chamber shallow. And these techniques very important in eyes have undergone vitrectomy, eyes with pseudoexfoliation, and also the eyes have undergone a suture IOL, either iris sutured or scleral-fixated IOL. And this is a post-vitrectomized eye, and you can see the AC pretty shallow. And I was using my go-to technique, use single cannula technique to unfold it, which is easily. But then the AC is so deep that I had to withdraw some AC fluid. But still, once my cannula came out from the eye, the graft become folded in again. So it's a battle between the graft and you sometimes doing when you do this complex surgery. So normally if I have a assistant, I will have the person use a curved tie, push down on the cornea. That would create a shallow anterior chamber, and I unfold the tissue, and then I will go under the graft to unfold it. Sometimes that there's some folds still remaining on the periphery, gentle tapping technique like that, and you can unfold the entire graft. So then continue to fill the AC with air. So this is the technique that I normally use to control the anterior chamber depth. If there's no assistance, then I have done is to one hand holding the curved tie, another hand to unfold the tissue and then inject the air. This is doable, but a little bit challenging. So the other case I want to share with you is that often we see this pretty complex eyes with complex anterior chamber. For example, this patient has gone through a shunt procedure and a trap procedure in the past, and among others, needling of the bleb and he's also pseudophakic as well. So when she presented to me, she had only very small window of anterior chamber. The rest of the iris stuck to the cornea, but she did have a very stable IOL. So during the surgery, at this stage, I already removed epithelium, so I was able to see the contour of the iris. So the visualization is a little bit challenging in this case. And to create an anterior chamber in such complex eyes, I first use a 30-gauge cannula to dissect, follow the plane and then remove this very tight adhesion. Because we're doing a DMEK for this case, so we don't really too much care about the endothelium of anything left. When the adhesion is really tight, the intraocular scissors often is necessary to cut this adhesion without damaging the iris too much when you put it. So there's a quite thick of the retrocorneal membrane in this eye. And sometimes they do bleed, as in this eye. And this eye is one of the eyes that bled the most. And eventually, the entire eye filled with blood, hyphema, by the big patient. So we use a intraocular epinephrine to stop the bleeding, and then followed by anterior vitrectomy to remove the clot. Eventually, the anterior chamber is formed and the bleeding stopped. Then I use the same technique, the graft injected in through the using the ICL injector. The visualization is a little poor, but because the blue cannula technique, you know the orientation of the graft, and that graft can be unfolded successfully. And this patient, amazingly, she was able to see 20/20 3 months out, and now I think 5 years out now, she is still 20/30, 20/40. So in such a complex eyes, it's feasible to do DMEK, but the key thing is to control the anterior chamber and control the movement of these graft inside the eye. As Benny and Alma mentioned, that in the eye eyes with shunts. The shunt is right there, and often you need to trim it and also avoid excessive movement of the graft inside the eye so that they will not have a excessive endothelial cell loss. So the key, I think, to do DMEK in such complex eyes is control. I mean, full control of every step of the procedure. And number one key is take control of the anterior chamber depth so that the unfolding is feasible. And again, thank you so much for your attention, and thank you for allowing me to share some of our surgeries with you. Thank you.
Thank you, Sophie. I think those cases were really complex for DMEK, especially the last one with hyphema inside, but managed very well. So now I invite Dr. Rajesh Sinha to give his talk on endothelial keratoplasty in aphakia.
Thank you, Dr. Namrata and Dr. Amar, for having me here in this this webinar. We're talking about endothelial keratoplasty in aphakia. Endothelial keratoplasty has evolved over time. Now it started with DLEK, and then DSEK, and then DMEK. We had ultra-thin DSEK in between. Then we have PDEK now. So over the period, we have understood that it's thinner the better. That's less the stroma in the donor lenticule. You have faster visual rehabilitation. However, there are certain cases wherein you have certain issues, like in aphakia, you have issues related, one, to refractive correction because you don't have an IOL. Risk of suboptimal tamponade because of lack of support of IOL. And then there is risk of lenticule displacement. And sometimes, as you could see in earlier presentation by Sophie, that you have to do anterior segment reconstruction, and in such a case you can have hyphema, you can have AC reaction. And in such a case, although DMEK or PDEK can be done, as Sophie has shown and Amar will be showing, but in most of the hands, a safer bet will be an ultra-thin DSEK, which is a good compromise between the ease of procedure and having a good outcome after the procedure. And various modifications have been described in aphakic eyes. One, Dr. Almer was showing the use of suture to retain the DSEK lenticule, and various other techniques have been used. One thing that everybody feels is that if you can place an IOL in its position, it will act as a scaffold to provide a good air tamponade. And we can put an AC IOL, as shown by Dr. Barry, if the anterior segment is good, the iris is nice, and with a round small pupil and a deep anterior chamber. However, in majority of these cases, you have these cases are quite complicated, and then in such a case, if there is no capsule at all, then in that case you have to do a scleral fixation of IOL. Now, the suture transscleral fixated IOLs have been used for the last so many years, and the intrascleral haptic fixated IOL have come up now in the last decade. And so the IOL, which remains stable by any technique, will provide a good tamponade, and that's why we performed a UBM study to look for the stability of the IOL. And this is a sutured IOL, transscleral sutured IOL, in which with the movement of eyeball, we could see that the lens is moving quite a lot and causing, it's touching the iris, causing pigment release, etc. However, in a glued IOL, or intrascleral haptic fixated IOL, you can see the IOL is quite steady, there's hardly any movement. So a more stable IOL is the one which is intrascleral haptic fixated one, and that is why we prefer ultra-thin DSEK with intrascleral haptic fixated IOL. We published this article a few years back, and this is the basic method that we use, and this is a microkeratome with which you remove the interior lamella, and then the posterior disc is created with the help of Trefine. And then you mark the sclera at 1.5 and 3 millimeter positions, and then you create a lamellar dissection, create a flap and a groove adjacent to it, and then you remove the epithelium to improve visualization, do scoring, and then you place the posterior chamber multi-piece IOL. This is a lens fixing forceps which is used to exteriorize one haptic, and then the second haptic also being exteriorized, and it is tucked into the groove made adjacent to the flap, and then fibrin glue is used to stick the flap into its position. And once this is done, you place the donor lenticule, you introduce it into anterior chamber with the help of a Gießen glide, and then put air for tamponade. Now, in certain cases, you have a bad iris, and in paucity of time, I will skip the video. But if you do iris reconstruction, and a technique of single pass pour through introduced by Dr. Amar is a very good technique to have a very good outcome, a good tamponade, and a good outcome after the procedure. Now, all these procedures can be done as a single stage, or you can make it a two-stage procedure. The reason why we felt that we should do a study to see the results comparing these two stages is that if you do it all together, it may jeopardize the success of the graft, and that was one reason why we, in one group, we did all the steps together. In the other group, we did the scleral fixation of IOL, did iris reconstruction, synechialysis, and as a second stage, we did DSEK. We found out that both are good. However, there's procedural ease in two stages, particularly in eyes with synechiae and vitreous in anterior chamber. Rebubbling was required more in single stage. Graft survival was better in sequential. And we do use venting. This is one indication, only one indication wherein I put venting incision, because most of these eyes are hypotenuse and the tamponade is not very effective. And in some of these cases, what I have found out that in spite of all these, because of the iris configuration, because of the hypotony, if you inject air in the anterior chamber, there's risk of air getting migrated into posteriorly behind the iris and behind the lens. So in such scenario, I've just devised a very simple technique. What I use a 30 gauge needle, and I inject 0.5 to 1 ml of fluid through the pars plana into anterior vitreous cavity. And as the pressure of the globe increases, it pushes the air, which migrates back into the anterior chamber and provides a good tamponade. And so far, I have done it in 8 eyes and have found that in none of the eyes, a rebubbling was required. So in conclusion, ultra-thin DSEK is a challenging procedure in aphakia, but it is a good compromise in aphakia in terms of ease of procedure and good outcome. A little bit of modification, a little bit of innovation can get a good outcome after the surgery. Thank you very much.
Thank you very much, Rajesh. It's really an excellent talk. Before we move on to the next speaker, I'll ask Gaurav Luthra. Any comments you'd like to give, Gaurav? Gaurav, unmute.
Yeah, can you hear me now?
Yeah, now I can hear you.
Okay, great. So I wanted to congratulate all the speakers for those amazing talks. And you know what I'm really amazed by is that for a cornea webinar like this, we have across all platforms between Facebook, IIRSI, and the web, almost 5,000 viewers from across the world. And you know, we are reaching out to a huge number. I never thought in cornea we'll do that. We do have a couple of questions also which are coming up. And I think because we are running late on time, we can put the questions at the end of the talks.
Thank you very much, Gaurav. I have Vishal Janji. I see him also there with us. So Vishal, big hello to you, Vishal. Few comments, Vishal, then we'll move on to the next speaker.
Sorry,
a comment from you.
Well, you know, so I've known most of these excellent presenters for such a long time, and you know, all the surgeries are amazing. Sophie's technique was really, really amazing. And you know, these are really complex cases. I completely agree with what Elmer said earlier, that DSEK has still got a very important place. One thing that that is sometimes missing, at least here in Pittsburgh, I can tell you, is from fellows training, we still, you know, try and tell them, let's start with a DSEK first before you want to graduate to a DMEK. You know, and the techniques that have been shown, it just sort of highlights the variability of each technique, yet an excellent result at the end of the day. I have been using Gießen's glide, and I'm sorry I joined in a bit late. I didn't know who presented before Elmer. I've been using Gießen's glide since my fellowship back in Melbourne, and I've had excellent results. You know, hardly any endothelial cell loss, any significant endothelial cell loss. Let me correct myself. So that's another technique that has always worked. And Namrata and Rajesh and Rasik Vajpayee, they've all been my mentors back in India and then in Australia. And Beast and Glide has always been a popular technique, even in the United States here. We use it all the time.
Thank you very much, Vishal. It's really nice to have you here with us. Well, we are moving on to the next speaker. So before I move on, introduce the next speaker, I'd like to tell all the delegates who are watching, please send in your questions. I know there's a huge global audience, which Gaurav Luthra has been telling me, from all over the world watching this EK webinar. We will be answering all your questions. Now, coming on to the next speaker, we have with us Namrata Sharma. So before I introduce her, I'd like to tell you one thing about her. I think it was Namrata who was instrumental into webinars and surgeonars, not today, not during COVID time, but 3 years back. She was way ahead of everyone, and today she is one of the key persons with Mahipal Sachdev from AIO as the president, and she's the secretary, and Rajesh Sinha is the treasurer, who are spearheading these webinar movements, educating all during this COVID crisis. Now we'll have to ask her to speak to us on intraoperative OCT guided DMEK and PDEK. Namrata, all yours.
Thank you, Amar, and thank you for organizing this webinar with such galaxy of speakers. I would be talking to you about IOCT guided DMEK and PDEK. And there are no financial or proprietary interests. And this is how a DMEK donor is prepared. And we have to prepare our own tissues, unlike in US. So it always helps if you have a IOCT, although I would say that for preparing the DMEK, perhaps you don't need it that much because the Descemet's membrane is stained with the trypan blue dye, and so you can see as the Descemet's membrane is being stripped. But as you lay it back onto the surface and put it back again there for a S-shaped stamp, then it does help you there. So after stripping this, a 3 millimeters punch is made, and the Descemet's membrane is then laid back again on the surface, which also can be picked up on the IOCT. And then subsequently, when you lay it back, you know that there are no gaps present between the Descemet's membrane. And when you open that lid, after flipping the corneoscleral rim, you can see it looks like a desmetocele actually. And then you flip it back again, and you make a S-shaped mark there. Actually, if you do have a IOCT, you probably wouldn't need S-shaped mark, but in hazy cornea, sometimes both the things are required, and it kind of helps. And this is followed by the triffonation, and then subsequently the graft is stripped. Now, this is a case of Fuchs dystrophy for which the cataract surgery has already been done. And even if you've not put a S-shaped mark there, you can still make out the orientation of the graft. When you're doing the desmetorexis, if there are any Descemet membrane tags which are remaining, one can address them looking at the IOCT and can remove every bit of tag there. And then this is the Descemet's membrane roll, which had previously been fashioned. This is taken into the injector, and this is then intracamerally injected into the anterior chamber. And when it goes inside the anterior chamber, you can actually see the configuration of the graft. And you have to get this configuration of the graft correct. So when you look at the configuration, you know that it is not the correct. It's still folded, and as you flip it up, it's upside down now completely. So there's no S-shaped stamp, but you can make out it's upside down. So some more fluid is injected so that the correct orientation is now up. And then you have to unfold it, get it to the center, and then put that air bubble there, and you know that the graft is quite stuck to the back of the cornea, and you can't even make out where the graft is. So this is the same case, visual acuity of 20/20 at week 1, and it's difficult to make out a graft just like in any DMEK case. Now in hazy corneas particularly, it is very useful. For instance, this, and we published this just this month. So again, all the remnants of the Descemet's membrane, which you can't see through the hazy cornea, can be addressed looking at the IOCT. And then again, the DMEK graft is placed inside. Now there's a S-shaped stamp there, but you can't make out, where the S is looking. So, but by the configuration of the graft here, now you know that the orientation is correct, and you know that it's endothelial side down. And this is how this intraop OCT microscope is useful, because the S cannot be deciphered. Very faintly you can make it out here now, but the folding, the pattern of the graft can be deciphered. So this is the post-op picture. Over a period of time it does clear up. Then This is a case where a failed DSEK was there because in a case where penetrating keratoplasty was done. So you can look at the configuration of both the wounds, the PK wound as well as the DSEK wound, and this failed graft is being removed with the help of the reverse Sinskey hook. And notice that there's some iris which is adhering to the back of the graft, which you can also see on the IOCT, and very gently this is removed out. And then when you are actually taking the graft into your injector, you can see it is upside down. So you get it to the correct position before actually putting it in this cannula, and then this is inserted inside. And again, by looking at the configuration, and in this we also had the S. So by looking at the configuration of the graft, you know which is the correct side up, and subsequently this can be then centered in position, and then the air can be injected. So the correct S is looking at you, and the configuration is also of the roll is also correct, so you know that you are in the right direction. So it is useful for these cases. Again, for eye syndromes, it's useful because you can actually see the adherence of the iris to the back of the cornea. Not that you can't see otherwise, you can see otherwise also. Only thing is it makes it a little bit clearer. And sometimes these dense adhesions are present which remain, especially bits of tissue which are present and connecting and communicating between the iris and the overlying cornea can be very nicely seen through this. And all the remnants are removed. It may not be possible to remove the entire thing piecemeal, so bit by bit one can remove it and again inject the graft intracamerally, and then with the help of the air the graft sticks to the back of the cornea. And this is the post-op picture in a case of eye syndrome. Now sometimes there are folds which are present in the DMEK graft. Now for instance in this case the desmetorexis was done, and this was followed by the injection of the graft inside, and the graft was centered. And when the graft was being centered, actually air bubble was injected, hoping that the fold will not be there. But as soon as the air bubble was injected, the fold still continued to be there. So in these cases, it is extremely useful because you can actually inject the. You can notice that there's a fold present there. So you go above that fold, inject a little bit of fluid, and from the other side inject air bubble, so that fold gets unfolded by looking at the Intraop OCT microscope and doing this maneuver. And by the IOCT, you know that you are in the correct plane, the fluid is injected in the correct plane, and the air is also injected in the correct plane. And then when the air bubble is injected subsequently, now this fold is kind of disappeared. So it helps to fine-tune your surgery. And this is PDEK, again it is useful here. So this is the air bubble which is being formed, the big bubble technique which is described by Amar, very useful especially because it expands the number of tissues that you can use for an endothelial keratoplasty, tissues which you cannot use for DMEK, you can use for PDEK. And again, the trypan blue staining of this is done, followed by the excision of the graft, which is done with the help of the Vanna scissors. And after removing the graft, this can then be placed inside the petri dish. And then subsequently, this is a case of, again, a pseudophakic bullous keratopathy from which the epithelium is removed, followed by desmetorexis. And then the graft, the PDEK graft, which had initially been fashioned, is then taken, is injected inside. And then there are little bit remnants which are there, which one can also see, and every single piece of the Descemet's membrane can be actually removed, and the graft is then injected. And this is a PDEK graft. It behaves a little differently because it's a splintered graft, so it's much more controlled as opposed to a DMEK graft, which kind of dances, and air bubble is injected, and this is followed by and this subsequently leads to the sticking of the graft to the back of the cornea. And this is the post-op picture of the same. As the epithelialization improves, the corneal clarity gets better. And these are just some of the cases which are done under IOCT guided, using IOCT guided techniques. And I'm sure it just helps to fine tune the thing, although it makes no difference with good clinical surgeons like we have on the panel. So DMEK and PDEK both combined allow the use of all the tissues irrespective of the age, irrespective of the pathology, and refinements in techniques and modifications will continue to occur. So thank you for your kind attention.
Thank you very much, Namrata. I think you've introduced us to this intraoperative OCT, and you were perhaps one of the first to move into this technology, which is really excellent, and introduced us now also to PDEK. So let's take it to the next level, and perhaps Ashwin will talk to us on PDEK, the tips and tricks. Ashwin?
Yeah, Dr. Namrata, can you just stop the share?
I'm just trying to do that.
It's on top.
Yeah, I'm doing it. Yes.
Thank you. All right, my topic today is PDEK, and I think I'll explain a little bit about PDEK. I'll just share my screen. I hope everybody can see my screen.
Yes.
Okay. First of all, thank you All India, and thank you IIRSI for having me on this panel. I think it's been absolute learning for me as well on this beautiful discussion on endothelial keratoplasty. So all you need to know about PDEK, I have no financial interest in any of my topics today. I want to go with a little bit of history and just start off with where it started off in 2014. Harminder Dua came out with a new layer and discovered that there was something new in the cornea, a sixth layer. How does this layer change things for us? How do you think it redefined corneal surgery a little bit in its own way? Well, PDEK membrane basically is a 25 micron membrane. This popping pressure already mentioned earlier before, about 766. It does pop, but it does not cross beyond 9 to 10 millimeters, and that's something very important to understand. Let's go a little deeper. Let's understand DMEK. You see the DMEK bubble starts from the periphery and then goes to the center. That's what a DMEK bubble does. Just the opposite of a PDEK bubble, that is the type 1 bubble. So here we are, type 1 bubble, which is the PDEK bubble, type 2, which is the DMEK, and type 3, sometimes you get a combination of both, which is ideal, not very ideal, and you can't actually use that. You probably could use the DMEK tissue in that and not the PDEK. How does this change things in a harvesting point of view? You can actually take a PDEK tissue, the donor age independent, which is basically 1 year or 2 years as well, which probably you can't do in a DMEK tissue, as the stroma and the predesmes are attached a bit too strong. These are some of the electronic images that we got from Dua himself, and if you see the small arrows on the left, that's the predesmes layer, and the big arrow is the desmes and the endothelial layer. So here's a pneumatic dissection. Why am I showing you pneumatic dissection? Because that's how today we harvest the PDEK tissue, and I'll just show you in a bit how this is done. The PDEK graft preparation. This is in steps, but here's a video that shows the same. We take a 30 gauge needle with a bubble. When the pneumatic dissection starts increasing the intracorneal pressure, you actually get a good bubble. Once you have this bubble, you pierce in with a knife or a side port knife, push some trypan blue into the bubble, and now circumferentially cut all around. This is if you want to do this manually. In the US, for my US colleagues, I think there are options available, and I'll show you that as well in images for now, but it's should somebody want to see more of this, there are S-stamped PDEK tissues available from many eye banks over there. This is how they do. This is a friend of mine, Mark Soper, who from Indianapolis. He kind of was helpful enough to send me his images of how he is doing this. Basically trephining from top using an artificial anterior chamber maintainer, and taking off that tissue from top and making an S-stamp into the bubble. If you see here, what I'm trying to show you is the bubble actually stays. In a DMEK tissue, that bubble will not stay if you have an open trephination point over there. These are some of the differences between the predesmes layer and the posterior stroma. This is just for a snapshot. Should somebody want to see this at a later point, this is only in interest of time. I'm moving on to showing you the recipient preparation. How does the recipient, and how we do it a little differently with the help of a trocar and an endoilluminator. So here's a pseudophakic bullous keratopathy case. After taking off the epithelium to improve visualization, I basically am putting in a trocar first. First I fix my trocar AC maintainer in. Once my trocar is inside the eye, I put in continuous air infusion. So once I have continuous air infusion, I always know that I can actually visualize uh, the margins of the, watch this over here, with an endo illuminator and a trocar with air infusion inside. When two Rusinski hooks, I can visualize the margin of that stripping very, very clearly. And you can do this even if you're doing a DMEK case. Honestly speaking, I found this very helpful in terms of seeing the tangential light when it hits the edge of that Desmet strip. It really gives a sheen to it, which really helps me improve my visualization before I can strip each tags, pieces, you know, the small, sometimes these don't come in a full piece. They come in piecemeal, and some of these tags can be disastrous when it comes to reattaching or attaching the donor button, donor graft. Now I'm making my wounds and keeping it prepped up, and that's filling it back with some saline. Next up, I'm preparing the injector system, basically removing the spring from the injector cartridge, putting that silicone tip back. Now, just like how I would in a DMEK tissue, nothing changes except that the graft is different. So here's my prep up ready. Now with saline inside the eye, I shallow the chamber, as is in a DMEK case I would do as well. The trocar inside the eye, I shallow the chamber. Now here's the only difference. I do a bubble, and I can actually use my reverse Sinski, which probably I cannot do in a DMEK tissue. The reason being the DMEK tissue would tear like a tin foil. A small thin tin foil, it would tear. And that is something that I'm using here, because this PDEK tissue has this advantage of this posterior stroma, which is really, really strong. The tensile strength of this PDEK tissue is extremely strong. In fact, if anybody has a chance to actually see a PDEK tissue or feel it, can try and pull apart a PDEK tissue and pull apart a DMEK tissue and test its own tensile strength. The guys in the US, when I taught them about this in the eye banks, they were surprised to see that we had this all under our noses. This is the pre-op and post-op picture of the same patient I just showed you, 45 days post-op. And this is a 3-week post-op of the same patient. Comparisons between the PDEK, DMEK, and DSEK. Again, this is not for me. This is basically for the viewers. But the most important point over here I would like to stress upon is the donor age independency of PDEK and DSEK, which is very important in the differentiating factor between DMEK and PDEK, because the endothelial cell count will be off the charts when you have a younger donor. One thing I'll leave you off with, and I think Dr. Amar is going to talk a lot more about difficult situations, and this is a really difficult situation, is when you have to do, I think Dr. Rajesh Sinha also spoke very well about this in aphakias and in really complex scenarios. You really have to lay a foundation. And a foundation can be laid by doing a glued IOL in these aphakic patients and doing a pupilloplasty. These two tricks have helped improve the results of endothelial keratoplasty in a humongous way. And I think I'm going to leave this with showing you a small animation of why this helps. Is because when you push air to push that graft on, the air actually goes into the posterior segment, and that's something you don't want. What you really want is, if you've done a pupilloplasty and a glued IOL, this acts like a scaffold, as what Dr. Rajesh already mentioned, and helps hold that graft in place for the next 4 or 5 days, which really is where you really want to benefit from these procedures. Thank you very much, and thank you.
Thank you very much, Ashwin. So before I ask Namrata to take over moderation again, I'd just like a few comments from Rajesh Fogla and from Terry Kim. Rajesh?
Hi. Yes, excellent presentation and nice videos. This PDEK is definitely useful when it comes to younger tissue. The only disadvantage is that you don't get the ideal size of the donor. The overall size is somewhere between 7, 7.5. And the edges, because you have to manually cut with scissors, you often tend to have some stromal tissue at the edge as well. We tried doing this technique back in 2013-14 when it was initially described as a hybrid DMEK. The overall outcomes, visual outcomes, were not as good as DMEK in the immediate postoperative, but I'm sure if you follow up these patients over a period of 6 months to 1 year, definitely the vision would get better. However, the other thing that we do with younger tissues now is ultra-thin DSEK. So if we have a younger donor and we are unable to do a DMEK, we would mount that on an artificial chamber, use the microkeratom to prepare an ultra-thin graft, and use it for ultra-thin DSEK, which also works very well.
Thank you, Rajesh. What about Terry?
Well, no, first of all, I just want to congratulate all the speakers on their excellent presentations. I mean, anyone, I think, even if they're a beginning DSEK, DMEK, PDEK surgeon or intermediate advanced, are going to get some great pearls from this. Just some general thoughts. I think for me, as I mentioned earlier, I'm using DSEK still primarily for my complex cases, but to me, the biggest prognostic indicator for successful DSEK cases, if I can get that air tamponade and that pressure very high. And I liked Dr. Singha's technique very much in that I'm going to try that in aphakic patients. But that to me is the most important, contrary to DMEK, where I don't think you need to have that high tamponade. And then also very important, I think, afterwards is the pupil IOP monitoring after these patients. I think it's important. For instance, in DSEK, I still do a very high tamponade for about 7 to 8 minutes in the operating room, and then I hold these patients for an hour laying back in the post-op holding area. Quite different from DMEK, where I'm still using 20% SF6 and just doing maybe a 2 to 3 minute tamponade in the operating room, very short post-operatively. But monitoring their pupil and their bubble and their intraocular pressure post-operatively is very important.
So
Thank you very much.
One question I have for Dr. Rajesh Fogla. Rajesh, how many percentage of cases now, what's your percentage of DSEK and DMEK? What's the ratio between
Well, we try and do a DMEK in almost all the cases, but when faced with a complex case with shallow anterior chamber, peripheral synechiae, where doing in a DMEK may be a little bit challenging. I think my next go-to procedure is ultra-thin DSEK. So I would say about 90% DMEK and 10% ultra-thin DSEK.
Okay, so I would now like to invite Dr. Amar Agarwal to give his talk on PDEK in difficult situations. A PDEK, a technique which was pioneered by him few years ago and has stood the test of the time and is especially useful because it suddenly expands the number of tissues that you can use for endothelial keratoplasty.
Thank you very much, Namrata. I hope I'm on screen there for you.
Yes.
Okay, so it's on full screen?
Yes.
So basically, if you see here in this case, I'm taking a very tough case. This patient is a pseudophakic bullous keratopathy case. Now, I prepared flaps there for glued IOL. I'm also making a scleral tunnel because, as you will realize, I'm taking out this epithelium, and you will see behind that an anterior chamber IOL. So obviously, I need to explant that AC IOL. I always have fluid in the eye. So you notice I've got a fluid now fixed inside the eye there. Somehow my flaps were not 180 degrees, so I'm just making it exactly 180 degrees apart, which is extremely important. Now, all such complicated cases, I always do a good vitrectomy, and even through such hazy corneas, you will notice I'll do a posterior vitrectomy because I do not know if the surgeon has done some mistake like dropping a nucleus or an IOL or something inside. Now, once I have done that, I'm going to now remove this AC IOL. The problem which I see in these AC IOLs are they get stuck to the iris. So you have to remove them very carefully so that we notice there is no extra damage to the iris created. You can see it's coming out in pieces. Slowly, I've removed one by one there, and you can see there pieces coming out of the optic and the haptic, but still some haptic is still inside. So I'm removing that. And I still see one more haptic behind, which is lodged onto the iridectomy. So I'm trying to remove it carefully so that I don't create an extra bleed in that. But notice while removing that, small bleed is there. That's why I always keep fluid in the eye so that there is a nice tamponade always happening. Now, once I have done this, my next step is to do a glued IOL. So I'm going to fix my IOL always in place there. So I catch the haptic. I'm using it like a non-foldable technique, very simple because I already have a large incision. One haptic in, out. Now I go in for the other one through the handshake technique, transfer the haptic from one hand to the other, externalize it. So you can see the handshake technique working very effectively. Look at the amount of haptic externalized. It's a lot. So I take a 26 gauge needle, create the Charrier's pocket, and tuck it inside. Now, so far, so good. Now, my next step is to do the 4th row pupiloplasty. And I'm just going to show it to you just now. Take a straight needle, Prolene, from one side. From the other side, take a 30 gauge needle through a paracentesis. Railroad the two. Once you have railroaded the two, bring the loop out. And Rajesh Sinha talked about this and Ashwin also talked about it. Now remember the number 4. All you do is pass 4 times. That's all. So this is a single pass only. And 4 times you have done it. So it's a 4th row pupiloplasty. Normally you do 2nd pass, 3rd pass. Every time you do a pass, you'll have chance of damaging the cornea, the IUL, or something like that. In this instance, a single pass, it's very simple. Here you can see I'm doing this. Now, what is the advantage of this? One, I made the pupil small so that the air does not go back. Second, the closed angle, if there is, will become an open angle. 3, I've also created like a pinhole type of an effect now, if you notice, so that if there is any sort of an astigmatism, that also gets neutralized. So looking at all these reasons why I feel in such complicated cases, you are better off with the pupiloplasty, and single pass 4th row makes life very easy. Now, once I have done that, I'm putting in air to see if my bubble remains inside, and it's remaining inside nicely. Now I take my PDEK preparation. So remember, for PDEK preparation, I'm taking a 30 gauge needle. I'm going to inject. You're looking at the endothelium, ladies and gentlemen, all of you. So once I do that, see the bubble? I've just gone in from the sclera, injected air inside. This is a type 1 bubble, as Ashwin talked about. It does not go to the periphery. So where is the air? You have endothelium, you have desmase, then you have the pre-desmase or Duas layer, then the air. So this is the type 1 bubble. If it went to the periphery, then it would be a DMEK bubble or a type 2 bubble. That means you will have endothelium, desmase, air, and then pre-desmase layer. So now once you have done this, just cut it in, just like how Namrata also showed in her presentation. I've injected some trypan blue inside to stain it. Now all I need to do to dissect it inside and dissect the graft. Now I also fix another cannula this time. Look, the first one was behind for fluid. This is a double infusion cannula. The reason is, in cases which are vitrectomized, people don't do DMEKs. For us, we only do PDEKs. We don't do any DSEKs. We don't do DMEKs. But the advantage with this double infusion cannula is the fluid from the back will push the iris IOL diaphragm anteriorly. And the one in the front will have air pump assisted PDEK going on. So I have air continuously inside the eye. Now all I need to do is take off this bad endothelium desmase, just like you will do a normal endothelial keratoplasty. So once I have done that, remove this, all I need to do is take my PDEK graft into any injector system, whichever one you're using, like in DMEK, same story, inject it inside. Once you have injected inside, we use an endo eliminator to check which side is right and which side is wrong. Inject some air inside. Now, once air is inside, the graft is attached at this time on the air pump on. So I've got my air continuously inside the eye and I can center it. Look how I can move the graft. You can't do that in a DMEK. The advantage is, 1, I can use young donor. 2, I can move it wherever I want. And I can manipulate it, so I can easily manipulate the whole graft. Now I've taken off my 2 infusion cannulas. That's how the case completed. Now the question comes, how did this patient behave? So let's look at how this case looks at the end of the day. Look at the patient 2 weeks post-op, and you can see the pre-order picture, 1 month post-op. And now you can see the patient again 2 months post-op. And look at the picture now, 3 months post-op, 20/20 vision. And finally, you'll see here the patient now 9 months post-op. So the last thing which I thought I'll just show you here is, I'll just 1 second go back to my thing here. And just, if you can just see that, you can see the book there. So this is it. Are you catching it, Namrata?
Yeah.
Okay, this is the book which we have been published on PDEK, which has been published by us, by the JP brothers also. And I thought we'll just mention this to you. So this is the basic thing which we see in PDEK. The reason why we don't do DMEKs and we don't do DSEKs is for the simple reason, we are getting young donors. 2, the manipulation is so easy. So we don't take any donor above 35 to 40 years. All our donors will be below that only. And approximately, we see that the results are so good. Thank you very much.
Thank you, Amar, for that great talk. And there's one question which has come up, and I would ask Dr. Yu for that question. If there's a NIRD and aphakia both, how would you manage it? I mean, what would be your approach? Combined
Well,
NIRD and aphakia.
Sure. So that's a little bit more challenging simply because if the patient is anoretic and it's something that's congenital, they've been able to manage the glare, that's one consideration. If it is a possibility that they also want that iris repaired and there's not enough iris root in order to fashion any form of protection there, then I would definitely suggest using a prosthetic platform where you can also sew the prosthesis onto the actual lens itself, do a scleral fixation of that process, and then consider some form of an endothelial keratoplasty. In my opinion, in a case that becomes this complex, especially when you are creating such a large wound, etc., I do think that going the route of slightly thicker tissue in the form of an ultra-thin or a nano-thin DSEK is preferable to me versus going PDEK and DMEK, but that is just my own comfort level per se. Not that that obviously, based on these wonderful presentations, is that an absolute necessity by any means.
Thank you. Thank you so much. Another question for Dr. Elmer too. Would you share your comments on AC maintainer? Elmer, is there?
In terms of an AC maintainer for...
Yeah, what do you think? I mean, should it be threaded or should it be, how would you?
I mean, I use a threaded one because it can be shorter on the entry and it's self-retaining so that I don't have to, I worry sometimes if it's not threaded that it may back out at an inopportune time. So.
One thing I tell you, Namrata, on this is we use the trocar AC maintainer. So the advantage is the trocar AC maintainer which you design goes through the sclera. So it does not damage the cornea at all. You know, you're passing through sclera, but approximately 0.5 millimeter from the sclera. Sclera is very forgiving compared to the cornea. So when you pull it out, you're absolutely safe and clear on that.
And there's one question, I think we'll take it up from all the panelists. For what or what percentage of cases do you do venting incisions?
It would be 0 for me.
Benny Jeng?
So I said that we shouldn't do it except under extraordinary circumstances. Right now it's 0 for me, but I know that there are occasions where some of the presenters have justifiably said that it'd be beneficial, but I do 0.
Dr. Bareilly?
Can you hear me?
Yes.
I don't use venting incisions either.
Liz?
I will do venting incisions if there is extreme difficulty with visualization and a failed cornea, not so much in a Fuchs dystrophy patient. But I will only place 2 because I do believe that if you place a tripod effect, it could create a little more irregular astigmatism. And I'm very specific about being 180 degrees apart. I do, in those cases, have a denuded epithelium as well.
Vishal?
Yeah, I think about the same in complicated cases. Taking off the epithelium and then do venting incisions. I would say that's about 1/3 of my cases.
1/3. Okay.
Namrata, just a quick, when I used to do them, I learned a trick with the venting incisions was actually to put them in before you put the graft in. Because once the graft is in and you're putting in the venting incisions, it's very hard to make them straight. And so doing the venting incisions before you place the graft when the eye is pressurized well will at least result in more normal incisions.
Yeah. Dr. Sophie Dang? Sophie?
No, I don't use a venting incision anymore.
Okay, and Terry Kim?
Actually, I am using venting incisions, but I think the key is doing it in an eye that's very highly pressurized. And I use a very sharp blade that has an angle like this, so the amount of opening actually is very small when you get to the posterior cornea, which minimizes the risk, hopefully, of any kind of epithelial ingrowth.
And Rajesh, I know you use venting incision.
I do it only in aphakic eyes when I'm combining all the procedures like doing a blue dye as well as iris reconstruction and doing an ultra-thin DSEK. In those cases, I use venting incisions.
And Amar and Susan and Ashwin, I don't think you use.
We never do.
You never need to do. So one more question before we take up the last presentation, and that is, what is the difference, and this is for 3 of you, what is the difference between an ultra-thin DSEK and a PDEK according to you? I mean, some people tend to think that it is an extreme form of ultra-thin DSEK.
if you want to go, actually, the thinnest will be after DMEK is going to be the PDEK. Because in PDEK, you are having desmase, endothelium, and the predesmase layer. That's it. There is no stroma now. In ultra thin DSEK, whatever you do, whether it is 60 micron or whatever you're doing it, you're going to have stroma in it. So my suggestion to people is the advantage which I see in PDEK is you don't have any stroma at all. It's actually simple. You just need a simple needle, 30 gauge, and all you need is the graft to do it. Issue is why we take only young donors is because I feel basically there's a huge difference. If you see the cases which you are showing are not simple flukes. There are very complicated cases like I showed you or what Ashwin or what Susan is going to show you. These cases I think are better off with PDEK. So when we started doing DMEKs and DSEKs and now PDEKs, we have stopped doing DSEKs, we have started doing DMEKs. The only thing I tell people is first prepare your graft. If my bubble does not come, I will postpone the case, I don't mind. But I prepare the graft properly, then only I will go in for the surgery.
Sometimes, how do you control the air? Sometimes you inject the air and the bubble bursts.
Yeah, so if it bursts, so that's what I'm saying. If the by chance the bubble bursts, then what you can do is we have another graft, it's okay. Otherwise, I'll postpone the case. The patient will not come inside the OR unless my graft is ready. So I'm very clear that the bubble has to be very good, clear. I get a nice graft, and then only I'm tracked for the surgery. Susan has got a nice trick which she'll talk to about on the fluid also, Susan.
I just want to add something for the US on the people abroad. I think the PDEK graft, when I started teaching the people in the eye banks in the US, what happened was they actually found it a big boon because they were actually throwing away those grafts for no reason. And they found it a big boon to actually start reusing those grafts for PDEK tissue. Unfortunately, it's not been popularized too much yet in terms of people actually asking for the graft. But there's a huge area where there's scope for improvement in terms of reutilizing those grafts which are going waste at that age group.
And also Lions Eye Institute, all these other eye banks are giving ready-made PDEK grafts which are stamped and stained. So they come to you ready-made. All you need to do is ask the eye bank, I want a PDEK or a DMEK. But if you're asking for a PDEK, what I tell everyone in the United States or anywhere in the world who's listening to me, please ask them for a young donor. Because that will be the biggest advantage which you'll get. And the manipulation, this DMEK dancing and all, no, we don't even worry about it. We don't have that problem at all in PDEK. So whenever you're asking in the eye bank, ask them for a young donor under 40 and you'll be able to get that from you in your hand.
So I think one thing which needs to get standardized is the cutting of the graft, because as cornea specialists, we all are wary about, touching the edge of the graft with the scissors. So I think that is something which needs to be standardized.
I'd like to make a comment here. One was about the size, about whether the bubble will burst. What I've seen is that, or rather what I do is that I start the bubble with air, and then I take off the air and then change over to trypan blue, which means I'm going to expand the bubble with trypan. Now, when you do that, you can go much more slowly and in a more controlled manner than with air. And so you can actually see it expanding and get it to a size you want. I always kind of, before every surgery, try to estimate the size of graft that I need. And I take a caliper and, put it over not without touching, but just hold it over the graft to kind of, can you hear me?
Yeah, we can hear you. But Susan, can you actually control the size of the bubble?
Yeah, that's what I'm coming to. That's what I'm coming to. So if you want, at one point, you'll see the fibers start to kind of stretch out. You can actually see that difference when you're doing it with trypan blue. The graft kind of takes a different appearance, the pre-desmate fibers, and that lets you know that if you're going to go on injecting more and more, it might burst. So that's the point at which I like to stop. And also you feel a greater resistance to putting the trypan blue in. So these are kind of two tips that would kind of let you know after you've done a certain number of cases that it's time to stop injecting now. Another thing I'd like to say is also that you can get much larger grafts. It's not always 7.5. In fact, I've got grafts as large as 9 mm sometimes. And that's not too infrequent either. So you can get large grafts with PDEK. I think the only thing is that you cannot always say in which donor eye you're going to get 7.5 or 9. But generally, if you see the corneoscleral, if you measure the white to white diameter of the cornea and it's a small eye, you're likely to get a smaller graft. And if it's a larger eye, you're likely to get a large graft. So that's a way that you can kind of guess before you actually inject that you'll get a large graft. 7.5 is generally easy to get in every eye.
So with this, we come to the last talk of the session, and that is air pump assisted PDEK and pre-desmate endothelial keratoplasty and failed penetrating keratoplasty.
Thank you. I'm just going to turn on my screen share. Sorry, just bear with me here. Okay, can you see my desktop now? Is my screen all right?
Yeah.
Okay. So thank you so much for organizing this symposium, Dr. Namrata and Dr. Amar. It's really nice to participate in this. My talk is going to be on pre-Descemet's endothelial keratoplasty on a failed penetrating keratoplasty. I have no financial interest in this topic of presentation. We know that thin membrane endothelial keratoplasties, which is a term that I like to use for DMEK and PDEK combined, are generally preferred all over the world because of various advantages that they have, like better visual acuity, less refractive error induction, and so on and so forth, better patient satisfaction. But they are generally more difficult to perform, and you do have a higher detachment rate than with DSEK. So a lot of surgeons prefer to do DSEK in complex anterior segment situations, which include aphakic eyes, vitrectomized eyes, sutured or glued intraocular lenses, eyes with large iris defects on aniridia, as was just mentioned here, glaucoma drainage devices, or eyes where you also have large incisions done simultaneously, for example, SICS, ECC, or explantation of IOL. And precautions that are taken in such cases include use of long-acting gases such as SF6 or C3F8, anchoring sutures, and the size of the descemetorexis being made larger or equal, and of course DSEK in complex cases. Now coming to specifically OPK, or a failed graft, a failed penetrating keratoplasty, this is how I make my graft, and this is how I just discussed. So I've made it with air, and I'm going to expand it with trypan blue, and without touching the graft, you can get a rough estimate of what the size is going to be. I'm just going to pause this graft here. We normally cut with scissors, but the tip to remember here, Dr. Namrata, as you asked, is that you don't hold the scissor vertically, you actually hold it horizontally, so it's lying on the base of the cornea, and there's very little edge touch actually around. Now that's important. If you hold the scissor vertically or in an oblique manner, you are going to get endothelial cell loss because you'll possibly remove it all around. But if you hold it lying flat and use a curved Vanas, your chance of any kind of endothelial cell loss is going to be very less. But in a penetrating keratoplasty, I actually like to use a trephine to cut the graft. In a PDEK also, and that's actually simple to do. What I do is I deflate the bubble by just withdrawing the air, and then once I've deflated it, I take the size of the trephine that I want and punch it. The reason I do this is because in penetrating keratoplasty, it's very crucial to get your PDEK graft of exact right size. You don't want to oversize and thereby, you don't want to oversize and thereby result in a detachment post-operatively. So in these cases, I like to do a trephine. Sometimes, now here it is, it may be a little difficult to get it exactly centered. So you might have to cut a part of it with a scissor, but you can try and center it as much as possible. And it really doesn't matter if you have a teeny bit of stroma. You need to go superficial though. When you're cutting that part, you have to make sure that you don't take too much stroma inside. Now, okay, sorry. Coming to the next slide. Yeah. So these are three techniques which I have described. One is the air pump assisted PDEK, the E-PDEK, and the hose descemetic scaffolding. And over many hundreds and hundreds of cases which I've done now, I've realized that these three techniques have really helped me do this surgery a very, very repeatable manner. I'm going to show you these three techniques. This is the air pump assisted PDEK technique, which I published in JACA in Konya in 2017. And this is a case of a PDEK in a failed graft. And these are the three techniques, as I said, that I like to use. And I'm going to show you all these three techniques one by one. So here's the graft. Important tips: when you make this incision, make sure that you're not going to touch the graft hose junction because you don't want to disturb that junction. It's nice to always remove the epithelium in tough cases because that gets you good visualization. You can do the rhexis here and complete the rhexis. You can see some posterior Seneca in the pupil. So these are some of the complex things that you might find, the dilated pupil or posterior Seneca in eyes that have previously been operated on. This was a soft cataract, so I've removed it with IA. In harder cataracts, you can go ahead and use your normal phaco maneuvers. I always use a hydrophobic IOL because I'm going to put in air and I don't want the IOL opacifying. I've put the IOL into the bag. And now this is again important. You remove all the viscoelastic. This is a really crucial step. You have to remove all viscoelastic. And then now this is what I want you to know. This is the antechamber maintainer, and I basically realized that when I started doing out PDEKs that it's really important to have this continuous flow of air into the eye, and that helps you keep a well-formed antechamber. You don't have that antechamber fluctuations that you otherwise have, and this helps you do the surgery in a much more repeatable manner. So I've got this air going into the anterior chamber, and this you can do by connecting it either to a vitrectomy machine or to some of the newer phaco machines. And you can see that I'm doing a desmetorexis. I'll get it back here. I'm doing an air pump assisted desmetorexis, basically an inverse desmetorexis, and the air actually helps you to visualize that that desmetorexis edge really well. And if you also notice, I'm going to make the desmetorexis a little smaller. Now, this I will explain in a later video in greater detail, but you can actually make it a little smaller. The other advantage, as you saw just now, of the air pump assisted PDEK is that you can the air holds the anterior chamber open, and so you can actually do a lot of maneuvers inside. For example, there was some remnant desmets here which I didn't want there in that particular area. If I want to make it smaller or anything else, I can go in and pull it out with a microforceps. I've got the graft in there. I've injected into the eye. Again, make sure that it doesn't come out, as Sophie had so beautifully explained. Open it, and here's how it's different from PDEK. I'm not bothered. If you look at that, the edges of the graft do not really bother me. So those peripheral edge folds, so I've unfolded the graft almost all over, except for those peripheral edge folds. And this is something that a DMEK surgeon might not accept. But I do accept this, and I've learned to have very good results. I've got very good results over the years. You've got the air flowing in. You just center the graft just as you do in a DSEK. So you've got all the advantages of DSEK, the maneuverability of DSEK, and the ease of performing DSEK, along with the anatomical and visual outcomes of a DMEK. So you saw me how I centered it, and then I've gone and opened those edge folds, again with air being infused. And then this is the same patient 1 month post-operative. So here's the next technique I'd like to show you is the endoilluminator assisted PDEK, which I published in JCRS in 2014. And again, this is a very nice technique even without the S-stamp. I've never used the S-stamp in any of my cases. I've never stamped the graft at all, because I found the endoilluminator makes all the difference, even in these hazy, really bad corneas. You can see that this is a really bad cornea, but with that endoilluminator, I'm able to do a phaco. I'm doing the rhexis, the peripheral iridectomy, everything can be done with just the endoilluminator light. And then you go ahead and use your other techniques, the ones that I just described. You can see how just with the use of that endoilluminator, everything actually comes into much better clarity than it was previously. You can do all these maneuvers because the air is being pumped in, and so it gives you that open and stable antechamber, a non-collapsible antechamber rather, and so you can go ahead and go on with your surgery. Let me show you the last technique. All right, sorry. So this is a very interesting technique, and this is what I call as the host dysmetric scaffolding. And this could also be used by beginner surgeons, but it's especially useful in all these complex cases. This, together with the air pump assisted technique, I would say, in fact, a combination of all these three in all these complex cases to be able to perform them successfully and repeatably. So this is again. This is a different eye. This is a penetrating keratoplasty that's being done. It was a child. Again, you can see the posterior synechiae. There was a fibrinous membrane, which I first thought was the capsule, and I did a rhexis on the fibrinous membrane, and then realized that there was the anterior capsule there again beneath it. So I did a rhexis again on the anterior capsule below that. This is again, this was a 12-year-old child. So I did a phaco with just IA, and unfortunately I left that superior cortex there, thinking that I would go ahead and get it later after putting the IOL, but I got a PCR, a posterior capsular, and now you can see that this is one of the, I'm doing an optic capture there, reverse optic capture. But you can see that this is a complex case because I'm doing it on a PK. It's combined with a phaco. There is a PCR. I've got a vitrectomy port there. So all these things, and it's a dilated pupil. All these things make this a really complex case with a high chance for detachment and postoperative complications. I'm doing a pupiloplasty here. And then I'm doing an IVT-assisted vitrectomy just to make sure there's no vitreous in the anterior chamber. I've got the air pump going now, and you can see again, I do the desmetorexis. Now in grafts, you really need to make sure that your Reversinsky is not digging into that graft host interface, because you don't want to open it up or dehisce it out. You can use this microforceps to just go ahead and pull out any tags, and then now you go in and check. You use your PDEK technique to make sure that the graft is in the right orientation. So that's important. Inject it in, and then use the PDEK technique again. You can see that it's beautifully seen without the S-stamp. So I've got it there. I've unfolded it. You can see those edge folds which I'm accepting. I float the graft up. It's a decentered graft. Again, I accept that. This you would not have done in DMEK. You would do this in DSEK though, and that's why PDEK combines the advantages of both these techniques beautifully. I've got that graft centered. I'm going to close up those sutures and then open those edge folds. So once it's done, the air is continuously going in, and as one of the speakers had mentioned earlier, that continuous pressurized air infusion in the eye actually helps the graft to adhere even intraoperatively. So even before you're done with the surgery, your graft is already attached. So there's no question of it detaching postoperatively. This is the child. And also, I forgot to mention that was another risk factor for this child, a low scleral rigidity. It was a child. So there was every possibility of this graft not doing well. And in fact, the child, as you saw postoperatively, did very well. So these are now this is just the second part of my video. This is a different video, and this is just to show that one of the biggest complications of thin membrane endothelial keratoplasties is actually graft detachment. And one of the reasons why this happens is if you have the host Descemet's membrane lying above the graft, this graft can detach in the postoperative period. And that's the reason everybody makes a larger descemetorhexis, a smaller graft and a larger descemetorhexis, so that you don't have accidental entrapment of the host Descemet's membrane above the graft. I'm sorry about that. So now what set me off wondering is, why would you want to leave that Descemet's membrane above the graft? Why not have it below the graft? So it's actually trapping the graft in place. The graft is kind of getting tucked under the host Descemet's membrane, and that helps to get you a scaffold in the postoperative period, which again prevents graft detachment. So make the descemetorhexis smaller, maybe in a few quadrants, and then tuck the graft in so that the host Descemet's membrane is actually supporting it in the postoperative period. So here you can see a case. I've done a smaller descemetorhexis, as you can see. You can use, as I said, microforceps to try and get it of the desired size exactly. Again, the PDEK technique showing beautifully how without an S stamp you can make out the orientation without even actually going into the anterior chamber with just an external non-touch technique. The air pump's been inserted in. You can see those peripheral edge folds. I'm opening up those peripheral edge folds, and now I'm going and teasing that host Descemet's membrane out from above the graft to a position that's now going to lie below the graft. So the host Descemet's is going to lie below the graft now. So it's actually with the air pump in place and with the air continuously flowing into the anterior chamber. You can see that the anterior chamber is held very stable, well open, not collapsing, and that helps you do this maneuver beautifully. The other technique that I also have described is wound scaffolding, and this is interesting because one of the panelists said that they would like to have the DSEK graft below, and one of them said, shorter than the wound length, and one of them said that they would like to have it longer than the wound length. But in PDEK, you can actually do this wound scaffolding technique. And I like this technique because if you have the wound slightly into the graft, it actually again acts as a scaffold. Don't have it more than 50%. Make sure it's not causing a Wick syndrome, but you can have it, and that's what's done here. You can see here, and also the host descemetic scaffolding on the sides. And all of this gives you a better kind of, getting the graft fixed into place and not detaching postoperatively. Use this in all kinds of complex cases, vitrectomized eyes, and all these eyes with AGVs, where I've been able to perform this surgery with trabeculectomies as seen here very successfully without any increased risk of graft detachment. So you can do this in multiple ways. You can either do a bilateral host descemetic scaffolding, which means you have the Descemet's membrane host Descemet supported in 2 quadrants, or you can have a multi-point host descemetic scaffolding, which means you just have bits and pieces here and there where it's supposed, or you can have a host descemetic scaffolding combined with a wound scaffolding. So all of these help to hold the graft in place. So the point that I'm coming to is, instead of having this gap between the graft and the host, have the host tucked underneath the graft so that it's actually, or rather have the host support the graft from beneath, so it's actually holding it in place. And this actually ASOCT shows you beautifully. This is the conventional technique where you have a gap between the graft and the host Descemet's membrane. And the next ASOCT is after host descemetic scaffolding, where you have the PDEK graft above and the host Descemet's membrane nicely tucking, and you can see where the graft, whether it's the section has the ASOCT scan has been taken, the PDEK graft holding the host Descemet's membrane beautifully in place. Here's again the reason why all these techniques are interconnected. I'm sorry, I'll come back here again. The reason why all these techniques are interconnected, and that's what happens when you don't have the air pump going. So you can have anterior chamber collapses if you don't have the air pump going, but you can do it in a very repeatable way if you have the air pump going. I'm sorry, actually, yeah, there it is. So again, you can see how the host Descemet's can be teased out with the air flowing, and you can get it out into a position to lie beneath the graft, and that holds it in place. And I think you'll see now that all right, and here's a little bit of wound scaffolding also being done. I think that brings me to the end of my video. I just want to show you one more thing, possibly I think it was at 4:20. Yeah, this is a patient of aniridia, and since this was discussed, and you can see how PDEK can also be done beautifully in a patient with aniridia. I think that would be a really case which would be extremely complex. Aniridia and aniridia IOL, a failed graft that is failed, everything together, and you're actually doing all of this and getting good results. The PDEK graft does not detach because of all these techniques that have been used, and it's also the very intrinsic quality of the PDEK graft, which is more tougher, robust, and more resilient, allows you to use all these techniques in a very, very beautiful manner. I think that brings me to the end of my presentation. Thank you so much.
Thank you, Susan, for those videos on PDEK. And one last message from each of the panelists. As far as the endothelial keratoplasty is concerned, we'll begin from Terry Kim. What do you say is the future of endothelial keratoplasty? Will we keep juggling between these techniques, or you think there's going to be something, which is going to come up which will replace all of them, or each technique has its, own place as of now? So unmute.
Terry, unmute.
Let me just thank everyone again for the invitation. I personally learned a lot and got a lot of great tips from it. We've all seen the evolution of these lamellar techniques improve over the years. And our techniques are outstanding, excellent for straightforward and complex cases, and we're giving our patients excellent visual acuity and outcomes from it. I do think the next kind of step in terms of the pioneering of endothelial cell transplantation will be transplanting actual cells. So the work that Kinoshita is doing is certainly groundbreaking, and to not potentially use donor tissue, but instead expanding endothelial cell populations and then planting them, I think will not only maybe shorten and flatten the learning curve, it will decrease the amount of donor tissue that's needed, but also it may allow for earlier intervention in these folks who maybe, as Kathy talked about earlier, are very interested in doing the less invasive approach. So I do think that's exciting technology in terms of the endothelial cell transplantation. I think we'll probably see that as the next step in terms of evolution of technique.
Sophie, what would be your, last take on it?
I totally agree with what Terry's comment. Looking into the future, cell-based therapy I think will take over eventually. It will take the time to get to the regulatory affairs. But I think that, again, when I see all these beautiful techniques from everyone, I learn a lot from everyone as well. But I think key thing is that what you're comfortable with. In our center, we have very complex cases, and I have no problem doing all these eyes with complex anterior segments using DMEK techniques, but I do also use DSEK as well in ACLL, aphakic eyes. So I think that it is important to understand the anatomy of the eyes and then the pros and cons of each techniques, and then make the best outcome, provide the best outcome to your patients. I think this is wonderful webinar that we have here.
Elmer, what do you think? I mean, you think endothelial transplant is very close by, or it's far away in the future?
No, I think there are going to be continued advances. There's probably going to be cell-based therapy. There's going to be pharmaceuticals eventually that will supplant some of the things we need to do. But I think perspective-wise, I mean, I think it's important that we remain invested in all of these techniques, because there are going to be roles for all of them, even PKP. And one of the problems that other specialties are running into, retina, for example, they no longer are able to teach buckles, but there are still some patients who need buckles. So, for some of us older surgeons, it's good to be around that we can still transfer some of those techniques. But the important thing is not to lose that tail end as we progress over time.
Benny, what would you want to say?
I think Elmer actually summed that up very nicely, which is what I was going to say, is that you still need to know how to do everything, all the way back to PKP. Worldwide, still more PKPs are done than EKs, and we all know this. In the US, sometimes people forget that because EK is so popular. But we need to know how to do every technique. There's a role for every technique. I think cell-based therapy is the future. but I don't know. It's going to be definitely a few years at least before that gets over here. And until then, we just need to be careful selecting the right technique for the right patient.
Dr. Barry Lee is here, or I think he's there. Yes. Unmute. You'll have to unmute, Dr. Barry Lee. Yes.
How's that?
Yeah, perfect.
Sorry, I had to get in the car. I'm heading to clinic now, so wish me luck.
Okay.
Yeah, I think we'll summarize. I think one thing from this webinar that's clear is that the U.S. we need to do better at PDEK. I think our numbers, if you look at the statistical report, are still low on that. So hopefully we can get the iBanks to help us more with that and get our PDEK numbers up. But I think it was an excellent seminar. I learned a lot today. Thank you.
Thank you, Doctor. Vishal is there, or Vishal is left?
No, I'm right here.
You're there?
Yeah, I agree with all the comments from the panelists, and it's pretty clear that all these techniques, although they are so diverse, everyone seems to be getting excellent results from these techniques, and cell-based therapies and pharmaceutical treatments would be very useful for places like India and China where we don't have much grafts. We didn't discuss that, but I guess it was beyond the perspective of what we are discussing here. All techniques, they work very well. So I would say whatever floats your boat, whatever is best for your patient, just keep on doing that and keep on trying new things. Thank you.
Rajesh?
Well, I guess what Vishal has very nicely summed up everything. And so I completely agree that till the time we get the cell-based therapy and pharmacological therapy, we'll continue having all these procedures. And every procedure has its own role to play, its own place. And it was really nice to learn those tips from everyone regarding their procedure. And that is how we are going to progress. And of course, endothelial keratoplasty is going to progress much more than what it is at present.
So, Amar, how would you sum it up?
I'd like to just first of all thank everybody who has come here, to invited all of you people. So nice. All of you have stayed back for the whole 2-hour symposium. I also want to thank the delegates from all over the world. I know a lot of questions I'm seeing who have been asking us so many questions from all over the world. I see them from Mexico, from South America, from United States. So many questions are coming in. I want to thank each one of you, and most important, Namrata, who's been the spearheading force with Gaurav Luthra, Rajesh Sinha, and Mahipal. All of you people who have done so much to educate all. Wish you all the very best. Stay safe. And all delegates at home, we have got to win, and we will win this battle. Don't worry about the virus. It'll all go away, and we'll be back to square one, hugging each other once again. Thank you very much, everyone.
Thank you, Amar. We would like to thank all the speakers, all the delegates who are watching us.
And Jaswinder from J&J has done a great job once again. Thank you very much, Jaswinder.
Johnson & Johnson, Jaswinder, and our team back in the AIOS headquarters, Mr. Kripal Rana and Raki, for coordinating everything.
Thank you very much, everyone. Bye-bye.
Thank you. Bye-bye.
Thank you.
Thanks, everyone.